So I'd like to welcome you for today's session. This is our second session for the champion group. I believe it has been productive since when we started. So today we'll be continuing with the pain management as we started the other week. So Erin will be taking us through the rest of the topic. So if you have question, you can put in the chat. You can also raise a hand and you'll be allowed to speak. So welcome Erin and welcome the rest of the team.
Hi, everyone. Good to see you. I hope you guys had a nice weekend and you had a good break. My name is Erin, and I am a palliative care nurse originally from Canada. And I started a few months ago working with AHN. I live in Kenya, in Nairobi, and we've been living here. And I just recently started with AHN as the supportive care lead, which is exciting. And I'm very excited to work with each of you and get to know you more over the next several weeks. So thanks again for joining us today. We are going to continue with symptom management. Symptom management is a heavy topic to discuss because we know, as I mentioned last week, that a majority of our patients, if not all of our patients, have a fairly high symptom burden. So I will just go back to those initial slides to identify that. So here, as we think about our patients, sometimes there could be an idea that some of their symptoms would actually decrease once they started on dialysis. But we know from research here published in 2017, 2016, and previously that for our patients, dialysis doesn't always improve their overall symptom burden. And it's really important, we as the frontline providers and the clinicians that are providing care to patients on a regular basis as they get their dialysis, that we begin to really advocate and assess their symptoms. So here we can see that 24 and 27% of patients stated that they felt tired. Even it worsened after they started dialysis. Our patients have pruritus. We viewed that last year. We talked about some good non-pharmacological ways to treat pruritus in our patients, as well as identifying how their dialysis treatments are going. We know our patients have sleep disturbances and they're not able to comfortably get enough rest throughout the night. Our patients also experience pain. Pain we're going to actually talk about in much more detail next week because there are some very specific ways we need to treat pain in our patients with kidney failure, and especially related to the dosages of standard opioid medication. And we also know, which we talked about last week, is that our patients' sexual functioning often worsens even once they start dialysis or 1 year into their dialysis initiation. So this is just a quick overview, knowing that there are some really serious symptoms that our patients are dealing with, and it's actually a large majority feel this way. This week, we are going to the remaining symptoms from the session, and I will share with you the slides as we continue. The way we've structured this teaching session is kind of in a format. So if you quickly or want to review something quickly, you should be able to check back on our WhatsApp group where I've shared the image, and just make sure you're on the right track with the symptoms. So the symptoms that we're going to cover today, if you do want to get out your pen and your book, I have mine here. To make some notes. You're obviously welcome to do that, or if you're at your computer, you can also make notes on Word. But structured it is on the very left-hand side. These are the things you want to look for in your patients. So this is how you're going to assess the symptoms that your patients may be experiencing. In the middle is our non-pharmacological. So that would be things that are not medical, specifically related to medications. And usually it's about the environment or alternative ways of treating a symptom. And then on the very far right-hand side is where we get into our pharmacological or the common medications that we use to treat the symptom. So the first symptom we're going to look at today is dyspnea. So dyspnea actually means shortness of breath. Shortness of breath is a symptom that is subjective as well. It's very similar to pain in terms of how we assess somebody who has dyspnea. We have to understand and know that. We obviously can assess someone's oxygen level, but dyspnea and shortness of breath is actually a subjective experience. Sorry about that. We'll get more into that as the course continues, as we talk about end-of-life issues for patients. When we begin to think about what can we do as clinicians and nurses to treat this symptom in our patients, the most important thing is actually propping them up and repositioning them so that they have a sense that won't be as short. So we often can advise pursed lip breathing, which is when you breathe through your lips as if you're blowing out a candle. We can also do abdominal or deep breathing with our patients to help them reduce their and relax. When our patients still feel very stressed, important things are opening windows. So if they're at home, feel this symptom, they can open up the door and window room. They can have a handheld fan. So the feeling and the sensation of wind blowing at your face can often help people who are experiencing shortness of breath. Even sometimes we can encourage family members to give shoulder or back massage, which obviously would result in relaxation. We can give oxygen if the patient has low oxygen levels, but it's not always a guarantee that our patients will be having low oxygen levels and shortness of breath at the same time. So we always do need to assess that. If our patients, moving on to pharmacological, if our patients have pulmonary edema and furosemide or extra fluid that the patient has. In our setting in Kenya, we don't have easy access to medications like fentanyl, and we definitely don't have easy access to intranasal treatment for that. So we usually would recommend a very, very low dose of morphine, and this is often, you can get it as a liquid. It's manufactured here in Kenya in our National Public Hospital, KNH. And you could prescribe 1 milligram subcutaneous, so into the fat tissue as a subcutaneous injection or orally. And this often changes the way a person perceives their shortness of breath and does a good job at treating this symptom. We then will move on to depression. So the other symptoms we'll look at today are depression. We'll look at cachexia, anorexia, and then we'll finish with abdominal pain. So for our patients with depression, we know that this is actually very common in our patients. We are not the best at, as clinicians and nurses, to assess our patients of their depression, and probably this is related to us feeling not equipped to know what to do when we ask our patients if they're feeling depressed. But 1 in 5 patients receiving dialysis have had an episode of major depression, but less than a quarter of those patients receive any sort of treatment. So we need to look for and assess our patients in terms of their reluctance to share about their mood. If they've had any change in their affect, you see your patients twice, if not 3 times a week, so you know them pretty well. If you've noticed a change in their mood or their affect, if they become disengaged or tense or irritable, these are all signs that potentially the patient is experiencing aspects of depression. Many providers see treatment of depression outside of their scope. And then we then put that responsibility onto their primary healthcare provider, which is actually a problem because in many of our settings in Kenya, Tanzania, and Rwanda, most of our patients don't have another primary healthcare provider. They may have a nephrologist, but again, oftentimes nephrologists also put the responsibility back to a primary healthcare provider. And we know that access to mental health providers, counselors, psychologists, psychiatrists is limited in our settings. So this is why we as a group we'll come together and kind of take charge of this, find ways to assess our patient's depression, and then also come up with a care plan of what to do when we acknowledge and we notice that our patients are severely depressed. Non-pharmacological best standards for treating depression is cognitive behavior therapy, which is done through a trained therapist. So in our referral centers, we may have access to a psychologist that would be trained in this type of therapy. And for our patients that have this as a severe symptom, it's really important that we refer our patients. So working as a team, identifying if there's a way that the psychologist or at least the counselor in the referral center is possibly able to come to the dialysis clinic, and also encouraging exercise. We know that exercise improves mood, and this can really help. Many of our patients do walk a lot, but we also know that many of our patients are quite weak, so they can't walk for long periods of time. Making sure that we come together as a multidisciplinary team can also help a lot. So when we can address spiritual as well as the emotional aspects of depression, we find that it is holistic for our patients. So SSRIs are considered the first line of treatment for pharmacological treatment of depression in kidney failure patients. And I'll go on to the next slide to identify what are the specific drugs that we recommend. So this was the core curriculum from the American Journal of Kidney Disease that identified dosages as well as the research, the recommendations for the intervention. So in this first study, the SSRIs, which are selective serotonin reuptake inhibitors, or sertraline, initial dose of 50 versus a placebo, was used for this patient, and unfortunately it didn't show any improvement for symptoms for these patients. In the next study in 2019, engagement with a trained therapist, as well as phase 2 SSRI versus cognitive behavior therapy, showed that sertraline was more effective than the cognitive behavior therapy alone. So what we can see is that there are effects. We do need to understand that we do need to treat patients. We need to come up with ways. We need to assessing patients for depression and work together as a team to know what is the best solution for our patients. As we go down in the chart, some comparative ideas from 2009 and 2014 related to cognitive behavior therapy. In this situation, the intervention was the cognitive behavior therapy versus routine care, and it did show for the 85 patients on hemodialysis after 9 months, there was a reduced depression symptom for that cohort of patients. And then again, the other one showed for 59 patients after a follow-up of 6 months that the cognitive behavior therapy showed a reduced depression symptom, and overall their quality of life had improved versus routine care. So then in relation to exercise, which we said was another option to support patients who are experiencing depression while having kidney failure, in 2013 and 2010, there was studies done where they were trying to compare intradialytic cycling versus routine care. So this is where they would have had access to a small pedal cycle that was done right at the dialysis chair. So patients were doing exercise throughout their dialysis treatment. These were small studies of 24 patients and then 44 patients with a follow-up at 6 months and 1 year. And it did show that this exercise routine throughout their dialysis treatment did show reduced and decreased symptoms. So there are some good research out there. There's not a lot of research to show improve this, but there is some, and you can review this as well after the session. So moving on to cachexia and anorexia, what this leads to is oftentimes our patients not wanting to eat and therefore losing weight. So when we assess our patients, we need to ask them about their taste, as well as their dry mouth. This is a symptom that often causes loss of weight in our patients and not wanting to eat. What we can do, we find ways to walk alongside and support our patients that are experiencing these symptoms, is making sure that they rinse their mouths regularly. Having some Vaseline or lip balm to apply to their lips can really help, as well as using lemon or hard candies, obviously low sugar or no sugar candies, to stimulate saliva in their mouth. And this can help quite a bit. For patients, of course, we know many of our patients are on limited fluid intake, so we do need to come up with creative ways to support our patients. For our patients that be having severe symptoms of anorexia, we need to talk to the treating clinician and the nephrologist on the team to possibly consider some liberation in terms of their dietary options. We know when patients have low mood, when they're experiencing depression and they have anorexia because they don't feel like eating, when we then on top of it say, you can't eat this, you can't eat that, it can be really difficult for our patients. So this is something we would do as a team. We would try to come up with a way to support patients so that they would have an increased appetite. Sometimes it's also related to their environment. So they may experience not wanting to eat because of the smell of eating or even the social nature of eating. Sometimes within different cultures, sometimes we ask people to kind of eat on their own, or we serve them to show them love, but actually eating can be very social. So if we can sit down and encourage our family members and caregivers to sit down with patients and eat together, it may actually increase our patients' desire to eat. We can recommend a low bulk and high calorie supplements for our patients if they are not able to take much in a regular diet. You can offer some appetite stimulants, although there's very limited resource and proof to show that it does work, but there's a recommendation of a medication you could try. And now on to our last symptom. So we'll cover this and then we'll go into how we at AHN are going to propose to begin the process of really assessing and taking this seriously, that we want to know how our patients are experiencing their symptoms. So we'll finish with abdominal pain. So pain is actually one of the most common symptoms in dialysis patients. Up to 50% of patients experience pain. And here you can see the references from the Indian Journal of Palliative Care in 2021. When we know that and when we see that our patients are experiencing abdominal pain, we need to think and assess for constipation, even reflux. Under treatment of this type of pain and other pain that patients experience, unfortunately is widespread, and it can lead to negative impacts on our patients' quality of life. Oftentimes patients won't admit or even seek relief because they've been living with chronic pain for many, many years. We need to consider non-pharmacological measures first. So we first want to assess pain fully, and then we come up with a plan using the WHO ladder, which has been a validated tool used in many settings. We have an adjusted ladder for our kidney failure patients, and we'll be going into that more detail next week on Monday when we talk about pain. We can use distraction techniques. So I know at AHN, many of our clinics are set up with TVs. This is one good technique if our patients experience pain to use that doesn't require any medication. So coming up with things that the patient likes, whether it's movies or music, and using that as a distraction from them always focusing on their pain. In specific related to medication, we want to avoid codeine and morphine at our normal doses because those are excreted. So the active metabolites in those drugs are excreted in the body through our kidneys, and therefore it's not always easy for our kidney failure patients to excrete that. So we oftentimes will see patients experiencing high levels of the drug still in their body. If you do need to use any medication to treat pain, we need to start low, so with low doses, and increase doses slowly. We also use adjuvants such as muscle relaxant steroids and anti-neuropathic agents to support our patients. We definitely, as I think Dr. Lloyd mentioned last week, do not want to use NSAIDs for our kidney failure patients because it does actively worsen their kidney functioning. And if, again, this is your only option, you do want to take consideration and discuss the pain management plan with their treating nephrologist. In terms of what we can do, we recommend using paracetamol up to 1 gram QID to treat pain as a first step. So that's usually accessible for many of our patients. Many of our patients might already be on this, so you do need to identify if they're already taking paracetamol. And then we can shift to tramadol. We usually use a reduced dose of 100 to 200 milligrams a day, but this is a good medication to use in our kidney failure patients. And then again, in, of course, many of our settings where we don't have access to a wide variety of opioids, low-dose morphine, being very considerate of side effects and how the patient is reacting to the medication is really important. And we'll go over that next week as well. So as we've talked about all of these symptoms, so from last week into this week, as we think about managing these symptoms, it's really, really important that we regularly assess our symptoms. So we can do this at the bedside or at the chair where the patient is getting their dialysis. We can do this before, so when they're checking in and we're getting them hooked up. We can do it obviously during dialysis. I know many of our nurses and nursing assistants monitor vital signs for our patients regularly, and they're often interacting with patients when they're taking their food and providing care. So we can also assess symptoms during that time, and even after our patients have finished their dialysis. So as they're getting ready to go home, if you as the clinical officer are concerned, you could sit down with the patient and assess their symptoms then. If we assess patients with a self-reporting system regularly, it helps us compare their symptoms. So if we were to do this once a week or every dialysis session, we could begin to see a trend. If a patient experiences a certain symptom all the time, this means that we need to come up with a plan and really identify what we're going to do. It also helps our patients identify what is the most serious symptom that's bothering them right now. Helps them identify how severe or what is the severity of the particular symptom and how it's affecting them. They will also, our patients will become more receptive to the ways that we talk about managing it. And we know that that will then help them adhere to any sort of recommendations, whether it's pharmacological or non-pharmacological, to address the symptom. So this is the new tool that we're going to be introducing over the next few weeks and months at AHN. So this is a validated tool to help clinicians and frontline providers assess patients related to their supportive and palliative care needs. So in the top left-hand corner, you'll see Palliative Care Outcome Scale. This is a validated scale that's been used globally. And the APCA logo there is the Africa Palliative Care Association. So they also have endorsed using this outcome scale to assess patients. And we also will be including the ESAS. So it is the Edmonton Symptom Assessment Scale, and it's been adapted for renal patients. So you'll see on at the beginning of this chart, this chart obviously will be revising this, so it will go directly into Clinicia. But if it was a paper chart, we would have our patient's name, the date, and any sort of identifier. We would then ask our patient what their main problems or concerns have been over the past week. This helps us identify what is the most important thing that our patient wants us to focus on. And it gives the ability of the patient to tell us, not us deciding for the patient. So then you would go to the list of symptoms. So most of these symptoms, if not all, are symptoms that we've talked about in the course study. But you would go slowly through and ask the patient how they're experiencing the specific symptoms. So the first one is pain. So you then would ask the patient to report, or they could circle, the number that best describes how they've been experiencing the symptom over the past week. So you would need to explain this to the patient a few times before they'd be able to fully understand and do it on their own. But 0 would be not at all. So if a patient is not experiencing any pain, they could circle 0. Then you could say that 1 is slightly. So if they're having slight amount of pain, they could say that. If they're having moderate, severe, or overwhelming amounts of pain, obviously the numbers would go up. And overwhelming is up to 4. Anybody that has reported a symptom of 3 or 4, most likely, of course, I realize there's a mistake in the scoring here. So a score over 5 is of great concern and must be addressed. So it would be a score over 3. I think the score over 5 would be if it was a scale of 0 to 10. So I can fix that. Sorry about that. If you have anyone that has reported severe or overwhelming symptoms, we want to come up with an action on that specific day of what we're planning to do. It doesn't always need to be medication, but sometimes it is. But we need to identify what are we planning to do for this patient in the moment. And that's why the yellow column there will help us just prioritize what we're planning to do after we do our assessment. So we then would continue. We then would ask our patients if they're experiencing any shortness of breath in the last week, if they're experiencing any weakness or lack of energy, if they're nauseous or feeling like they're going to be sick, if they vomited or they were sick, so they did throw up, if they're having poor appetite, constipation, sore or dry mouth, drowsiness, poor mobility, itchiness. Again, that goes to the pruritus, any difficulty in sleeping, restless leg, changes in skin, or diarrhea. So I know at AHN we actually do quite a bit of symptom assessment, but I think this list is very comprehensive. So if we are able to find a way to get into the rhythm and routine of doing this, we will be able to fully understand what our patients are experiencing and then come up with really good holistic action plans. And then at the very bottom of this chart, it says there, if there's anything that has not been mentioned above, then you can write it in. So you as the team could help with that. Then as we continue into palliative care outcomes, we shift to this second scale that we will incorporate into our work. So this has been rolled out all over Africa and has been endorsed by the Africa Palliative Care Association. And this looks specifically at our patients as well as the family caregiver. So we may not be able to assess our family caregiver every week or every session, depending on if they attend a session. But it is important that we come up with a plan of how to assess even our caregivers in terms of how they're experiencing the care that we give them. So the first question in black there is, have you been feeling worried about your illness in the past 3 days? So again, this is a 0 to 5 scale. 0 is not at all, and 5 is very overwhelming. If you had a patient who said they're not feeling worried, they'll probably put a 0. If they're feeling very worried, they would have to put a 5. And then we would need to come up with a plan of talking more about what they're worried about, understanding their underlying reason for the anxiety they're experiencing, and come up with a plan of what we would do. The questions in orange have the kind of switched mentality. So if we were to think of 0 as not at all, we don't need to do anything for that symptom, and a 5 being very overwhelming, and we need to do something for the symptom, that has switched for the next several questions. So you'll understand as I read them out to you. So over the past 3 days, have you been able to share how you're feeling with your family and friends? So if a patient says 0, no, not at all, I haven't been able to share, that's actually of most concern to us. And if a patient says, yes, I've been able to talk freely, and they put a 5, then that means that they're comfortable and there's open communication in their family, and they feel well supported. So in this situation, if we have someone reporting a 0, we need to understand what is going on with that. Why are they not feeling like they've been able to share how they're feeling? Why are they not able to have open communication within their family and friends? The next question is, over the next 3 days, have you felt that life is worthwhile? Again, if a patient reports 0, no, not at all, that is a great concern to our team. So if a patient is not feeling like their life is worthwhile, that means they could be depressed. It means that they could be feeling that they don't want to continue with their dialysis. They have other serious stressors in their life that is causing them to feel this way. And we need to understand why and what we can do about that. The next question is, over the past 3 days, have you felt at peace? Again, if someone reports 0, not at all, that is something that we need to be concerned about. They could be experiencing spiritual distress. We'll get more into that as we go through the course, but this again is a really important symptom that we're assessing for our patients. And the last one there for our patients is, have you had enough help and advice for your family to plan for the future? So if a patient says, no, not at all, or 5 is as much as I want, that will impact what we plan to do. So if a patient is saying they have not had enough help and advice for their family to plan for the future, then we need to highlight this, and we need to come up with a way to potentially address some psychosocial issues, or engage with the family through a family meeting to help them, because the patient is feeling like they're not able to plan for their future. As we shift on to the family caregiver, we can ask the following questions. How much information have you and your family been given? If the answer is none, we would rate that as a 0, and that would be of much concern for us. We want to make sure that our families have been given information, and as much information as they want. As you can see there, 5 is as much as they wanted. So if if a family member is comfortable with the amount of information they've been given, they could rate it at a 5. And that would show us that we are doing well in terms of our communication and the family is feeling supported. The next question is, how confident does the family feel caring for the patient? So oftentimes this is related to home-based care, and it could even be excuse me, related to supporting a patient to come to dialysis. This is quite important for us to know as we help a family who are the primary caregivers. So if they're very confident, that's great. If they're not feeling confident, that means potentially that the people have negative outcomes because they don't have support even when they're at home. Excuse me. And the last question is, what has the family been feeling worried about the client over the last several days? So if the family has not been worried, that's great. That means that there obviously is okay quality of life for the patient. The family is feeling supported and they feel like they can manage. If they're very worried, it shows that the family and the caregiver is actually experiencing anxiety and maybe even having things that we can address. So psychosocial, financial issues, even spiritual amounts of worry can really affect a caregiver. And it is something that we should know and understand so that we can support them. So these are the 2 holistic assessment tools that we are planning to use over the next several months at AHN. And this will begin to show us the current condition of our patients as well as their family members. And because these are validated tools, it helps us know that as we collect this data, we can then begin to show, is the type of care we're giving helping our patients? Is it improving their quality of life? And this is really important to us. So these are the patient-focused questions, which we went through, and these are the caregiver-focused questions. So we're going to get into our case now. So it looks like we have about 10 minutes. We'll talk about this, and then we have a few questions. So I'll be interested for you to engage on the chat, or you can also raise your hand. So I want to introduce you to Mrs. Najaguna. She's 75 years old. She is a known case of hypertension, ischemic heart disease with heart failure, and she also has been on dialysis due to chronic kidney disease for the last 5 years. Her current socioeconomic status is quite poor. She can't afford any extra dialysis throughout the week and often has difficulty paying for the transportation to get to the clinic. She's been complaining to the nurses about chronic pain and persistent shortness of breath or breathlessness before dialysis. She has limited mobility and is fully dependent for her activities of daily living. So that means she needs help getting dressed, taking a shower or bath. She needs help eating and preparing her food and that sort of thing. She shared with the team that she doesn't want to be a burden to her daughter anymore, who is the primary caregiver. So in this situation, what would you as a clinician do first with this patient? So the patient's identified a few things. What would we do first? After talking about symptom assessment and management, we also want to know, how do we identify what is most important to our patients? And then the last question we'll talk about is dialysis absolutely necessary? So I'm going to stop sharing my screen. I'm going to put these questions on the chat, and I'm very curious to know what your thoughts are. So the first question is, what do we do first for this patient? We've identified some specific symptoms, so her socioeconomic status. She obviously has a variety of NCD. She has hypertension leading to heart failure. She's got ischemic heart disease. She has chronic kidney disease. She's also elderly. She's 75. She's complained to the staff about pain and breathlessness. Yeah, Lydia, we can definitely ask her, right? So she's come into the clinic. She's complained of pain and being short of breath. We say, okay, what's the most important thing right now that I help you with? It seems like she's coming in for her dialysis treatment. So she'll be sitting in her chair. Is there something specific we can do related to the symptoms that she's talked about? Probably the socioeconomic status might be something that we will take into consideration, but is that something that we're going to address first? It could be if we had a social worker, or maybe the referral hospital has a department that supports patients that are not able to financially manage. Okay, some good thoughts coming through. First, we should start on pain management. Good. So let's see what pain medication she's had. It's chronic pain. So it could not specifically be related to her dialysis. It could be related to osteoarthritis, although we didn't mention that in the history, but she's also 75. So it could be back pain. First, we could assess her pain. So we could understand that better and then possibly use paracetamol. Perfect. So we could check if she's on any medication for pain, check the dose, and then see if her dose needs to be adjusted or we need to start her on some medication. Okay, Dr. Mazar is saying it's really important that we identify the shortness of breath. Is it because of the heart failure, or is it the kidney disease, the chronic kidney disease? Because the way we would support the patient obviously could be different, right? If she's having her heart medication is not being effective anymore, or the fluid, she has edema, we need to think about that for sure. Shortness of breath also can be, is subjective. So she's told you that she's short of breath when she, before dialysis. So, I mean, it could be from her activities. So it could potentially be something we could solve non-pharmacologically. Maybe our clinic has access to a wheelchair and we could assist her from her car or from the public transport that she came on with a wheelchair up to the clinic. Maybe she's getting short of breath because she has to walk that far distance. Very good. Also the